Thank you. Thank you for inviting me to Egypt. It's nice to be back here, especially if coming from Sweden, where we have very cold weather and snow, to come to this pleasant place. This is really a warm part for a person from Sweden. Yes, I would like to discuss with you quantification and computer-aided diagnosis for the closest after. As I said, I'm involved in this subject both from a research point of view, connected to two universities in Sweden. I also work at two university hospitals with nuclear medicine together with my colleagues there. I'm also involved in quality assurance in what's called Referral in Sweden, which is an organization that looks at quality in medicine, not only nuclear medicine, but clinical chemistry, pathology, and different fields of medicine to look after quality there. And also in the company Exini, where we transfer our research result into something that really can be useful in clinical practice. Well, I'll start with what we are doing in nuclear medicine. We get referrals from our clinicians and we produce reports which we send back to the clinicians, and they make clinical decisions on our reports. So the reports are really the end product of what we are doing. They are the really important things that we produce. And for the clinical persons, cardiologists, oncologists, the other things in here could be sort of a black box that don't know much about it, perhaps. In this place, we have, as you mentioned, we have radiopharmaceuticals, we have cameras, we have different sort of processing steps, and we also have, I think, to read images and to make the report. So this is the part which I'm also work with as a specialist in nuclear medicine. I'm doing reading of images and I'm doing the report. And the question today, do I need a software for quantification or computer-aided diagnosis? Well, if somebody has asked me some years ago, before I started to work in this field, I would probably have said that, well, I don't know, because at that time I had something like 15, 20 years of experience in nuclear medicine. I looked at many images before. I could see that most of the examinations I look at many are very easy. Some are, of course, more complicated, but at the end of the day, I have always reported all the scans. So, yeah, perhaps, but perhaps not. I was not convinced. But now I've worked a little more with projects in this field, and I will share some experience with you from these projects. And if we look at this again, this sort of box of what we are doing, you can say that we are sort of measuring the quality in sort of different ways. When it comes to the technique, we make camera control of the cameras, and we know we have good radiopharmaceuticals. But the reading and the reporting, how do we know that this is really good? My feeling, of course, we are all doing our best, and that was also my feeling, that I'm doing the correct interpretation and I'm writing a good report to the clinicians. But that is only sort of my subjective assessment of self-assessment. So what happens if we make sort of a project where we measure the quality of these things as well? Well, some studies have been done with this quality assurance regarding the reading, and I will give you some examples. A couple of years ago, we sent out bone scans to all hospitals in Sweden performing whole body bone scintigraphy. And they got the scans on CD, so they could put them up on the screen and make the interpretation in the same way as they were doing with our own clinical cases. And they reported to one of my PhD students their interpretations. And she had gathered all the sort of data, and we have follow-up of all these cases for several years, so we know sort of a good gold standard. And what we could see is that, of course, most of the cases were correctly interpreted by nearly all of the doctors, but not all of them. This is a case where about 50%, 18 of the 45 physicians, they missed metastatic disease in this case. And there were more cases like this. So it could be that when you see many cases, you miss some of the significant hotspots. You don't see them, or you see something else. I think that is a fracture, for instance, and you miss that there is something in this part as well. So this is something that we know can happen. We have also looked in another study where we sent, again, images to Swedish physicians, and they reported these scans, but this time they also gave an indication what is the probability or likelihood that the findings are consistent with metastatic disease. For instance, this patient with a hotspot in one of the ribs, is that likely to be metastatic disease, or is that likely to be something else? Well, the opinion was quite diverse among about 50 to 60 doctors in Sweden. Some of them indicated that they thought it was a sort of less than 5% probability that this was metastatic disease. So, for practical reasons, they were quite sure that this is not metastatic disease. Some others said it was more than 95% probability. So they were sort of, it was definitely metastasis. And we had sort of all the different levels, we had sort of doctors giving their vote for this. So they didn't agree on how to interpret this type of finding. We have done similar things with myocardial perfusion scans, and at that time we both measured the differences between, in this case, 3 doctors looking at the same scans, but we also measured intra-observer variability. That is, we gave the cases not once but twice. We copied all the cases and gave them twice, and they didn't know about this, so they just went through all the cases, and then we had 2 interpretations for each examination. And they had to indicate on this 4-grade scale if ischemic or coronary artery disease was present or not in, as I showed you, had the LAD territory in this region here. I showed you the first line. And this is the interpretation by the 3 doctors. Sort of Dr. Red, one doctor made these 2 interpretations, one made these 2, and the third one made these 2. So you see, in many cases, they didn't come to the same conclusion when they were looking at exactly the same image at different locations. And now I've shown you some cases, but also when we look at materials and show the results from those, this is the same image I showed you in the beginning, but we had 59 different bone scans, and we could measure sensitivity and specificity. And these are the 35 Swedish doctors looking at these cases. And you can see that they all had quite a good specificity. Most of them had specificity between 90 and 100%. So but they had a sensitivity from just about 50% to 100%. So many of the doctors missed some of the cases where the patient really had metastatic disease. So this was true also for a type of examination that we have had for many, many years. I mean, those scans has been there for decades. It's not, for instance, that we are now going into an area with PET-CT, which is where we are sort of newcomers, all of us are taking our first steps, and that is for sure difficult. But this is something, sort of a bread and butter examination, which all nuclear medicine doctors are very familiar with. Well, is this something special with nuclear medicine, the result I've shown you, or is this something special with Swedish doctors, that Swedish doctors are not sort of really good at this? Well, if we look in the literature for similar studies in other fields, we find we have the same results, the same findings. This is a study with coronary angiograms from New York, where at the hospital they looked back at more than 200 cases where the sort of actual management or actual reports were classified into if they gave the advice that the patient should be revascular resectionized or not, if they had sort of significant stenosis or not. And then they took an expert panel, the best cardiologists they had, and they made a consensus of all these cases in blinded fashion, so they didn't know about the actual reports given. And this is the result, where you see that of these 209 cases, 24 were given an unnecessary treatment if we should believe sort of that the experts are making the best recommendation. Also, 27, they didn't get any treatment because of the clinical report, but according to the experts, that would have been a good idea for these patients. So, nearly 25% of all these cases were sort of misinterpreted, and the consequences for the patient were both unnecessary treatment and denied an essential treatment. So it's not only nuclear medicine, it seems to be, it's not only Swedish doctors. This is something that we find in different places where we make this type of analysis. So reading is not always easy, and there could certainly be a good idea to have some sort of some tools to make it more accurate. Now to reporting, which is the sort of most important document which we give to the clinicians. We made a study in Sweden where we sent bone scans to the physicians, and they reported them as their own clinical cases, and it was the same cases, and we compared the different interpretations. And this case, with the hotspot in the spine, was described in different ways. We had 16 different expressions of words used to describe the likelihood of probability that this patient really had metastatic disease. I've listed them here in small letters. It's not meant for you to be read because it's in Swedish, but the point is that we describe it in different ways, and so that oncologists, they have to sort of interpret many different words or expressions for the same type of findings. Well, is this a problem that we use different words, different expressions? Well, we studied that in the hospital where I work, where we took all the expressions, words we had used in myocardial perfusion scanning patients, where we described the likelihood that the patient really had ischemia or infarction. And we listed all these words or expressions we have used during 1 month. This was our own reports, which we have sent from the department. And then, from that list, we gave that to the 9 doctors we had in the department at the time. And they all individually had to score on a scale from 1 to 10 if they thought it was a low probability or high probability that this was ischemia or infarction. And as you can see, some of the words like this, this means no sign of ischemia. Then all but one of the doctors said that then you can be practically sure that this patient doesn't have ischemia. And so we had some of the expressions were very good. They all felt the same for these words. And the same with these, which is possible ischemia, probably ischemia. They all felt that this is meant that it's rather high probability, but not very high. It's not sort of 10, but it's an 8. So they agreed very much on that. But also interestingly, there were a couple of several words or expressions where we, as nuclear medicine doctors, disagreed on what they really meant. And these sort of Swedish words, I can translate some of them, is can be present, cannot be ruled out, etc. These type of words are difficult to pinpoint exactly, is this high or low probability? And you see, we have a scale from one doctor saying this is 1, it's nearly, or in this case 1, and you have one saying 8, so one doctor says it's almost sure that the patient doesn't have ischemia, and right this, and another one says 8, that means that this is nearly certain that this patient really has ischemia. So this with using many different words, and the raw use when we dictate different words can be confusing, because then we have clinical cardiologists reading these words also have different opinion about what these words mean. Another thing with reports is that we have different style. We can write long reports with describing in detail the findings, the images, and possibilities of this impression. We can have short ones. We can have more or less sort of concise reports. We can have images or not. In Gothenburg, where we make cerebral blood flow or brain scans, we changed the style in reporting these from more or less this type, where we went through all the slices and reported slice for slice what we saw here, to a more quantitative approach, where we could be very more specific and say something like the normal cerebral blood flow period, impression, normal brain scan period, very short. And when we started with that, we got a question from the neurologist, we haven't got your report for this patient's brain scan, and the patient is coming this afternoon. Well, we said, we have already sent it. No, we've got one short one, which says normal brain scan, but it's usually sort of one-page report, so we want that. And we had to explain that this was a new approach to be very more concise and short in our reports. And when we did that, they were very happy, the neurologist and neuropsychiatrist, that it was so much easier to sort of interpret our reports. So, if I had the same question today, 5-10 years later, after being involved in many different projects, do I need the software for quantification and computer-aided diagnosis? I would definitely say yes, even though I have 5-10 more years of experience in this field, because I realized this is a very difficult task we have. And what could the benefits, we see the problem as I pointed out now, but what could be the benefit of using the computer in this way? Well, go back to some of these studies where we also looked at that. This is the case I showed to you in the beginning, where I said that 18 of 45 of the doctors, they missed this metastatic disease. These doctors, they got the same images again 1 year later. We randomized them again so they didn't remember their first interpretation. But this time they had software with computer advice. And this time, only 5 of the 45 missed the metastatic disease. So we went from 18 false interpretations to just 5. And then if we summarize that, and not only for this case, but for all the 59 cases, this was the one I showed you at the beginning with the sensitivities from 52 to 100%. The first session. The second session with computer advice, 1 year later, we had these results. And we should see that the dots representing the doctors are much higher up. We had an increased sensitivity of 10% as mean sensitivity. So we saw a positive effect of the computer advice. We have done similar things for cardiac scans. This time a study in France where French physicians looked at cardiac scans, looked for ischemia. We saw an increase of 5% in sensitivity with the use of computer-aided diagnosis without having any loss in specificity. Again, is this something that is special for nuclear medicine? Well, things like this, like computer-aided diagnosis, this is available also in other fields, for instance, in mammography, computer-aided detection with marks in the mammograms for sites where the doctor should look specifically careful not to miss anything, has been used now for several years. And this was a study where 2 physicians looked at patients and increased their sensitivity with 5% using this type of image for this type of computer-aided diagnosis. So this is nothing specific in nuclear medicine. We see the same result for other fields of in medical imaging. This, if you remember, this study where we gave the 3 physicians the same cardiac scans twice and reported. After that, we waited 3-4 weeks, and they had all the cases once again or twice again, but this time with computer advice. And what we saw, this is sort of, I've selected, of course, a very good case, but to illustrate what happened, that they not only sort of decreased their disagreement between each other, but they also, as in this case, where they disagreed with themselves the first time, they agreed all with this interpretation, which showed to be the correct one. And when we looked at all the 135 cases, we could see that a significantly reduced intra and inter-observer variability. And interesting, this was the 3 physicians was the picture of sort of one, which was a sort of junior doctor, one was an experienced one, and one was a very experienced one. And even the very experienced one, with sort of 25-30 years of experience in nuclear medicine, he decreased his intra-observer variability. It was easier for him to come to exactly the same interpretation for the same case when he used the computer instead of just looking at the images. So we look at this not as a sort of tool to use also for, not only for the most junior nuclear medicine specialists, but also for experienced. In a similar way as I often compare it with sort of a pilot using an autopilot. I trust that he can take me from Uganda to Frankfurt tomorrow, but I'm happy that he's using the autopilot to make him avoid mistakes. And that he uses the computer technology does not mean that I don't trust him and think he's a very experienced pilot. But I think it's a good idea to use all the tools we have in a good teamwork to come to a very good result. So therefore, we use it not only for the junior doctors, but also for the experienced. Now some words about quantification. It is common in nuclear cardiology that we use quantification with ejection fraction and volumes of the left ventricle. Not in nuclear medicine in the oncology field, but we have started with that now in bone scans. And I will show you 3 bone scans from prostate cancer patients we made many years ago. At that time, we only reported them in a sort of detailed report, and what we found reported was no metastasis in this case and metastasis in these 2 cases. It's difficult to see here, but we see a hotspot, not so much in this case, and quite a number of hotspots in this case. So that was the message that the oncologist got on these patients. If we have done this today, we have been able to make a quantification as well, and the result of that with the bone scan index, assessing the sort of extent of skeletal involvement by tumor in these patients. For the figure that shows if this is very severe disease or if this is not so much so. So when we do an analysis now many years later, we come with a bone scan index of 0% in the first case because there are no metastases, but 0.2% in the second one and 2.3, which is a rather high value in the third one. So that is something that we will be able to supply our oncologists with. And then you can ask, and what is the important thing for oncologists? But that is something we now do in looking into the clinical impact of that. And for these patients, when we look at the survival time, because this was, as I said, done many years ago, these 2 patients, they died 6 years after the bone scan, whereas this patient, he died 6 months after the bone scan. And I only show you 3 cases, but when we look at many cases, we have now 450 cases where we follow them from the time of diagnosis, and we have a bone scan and follow up, and we see that the bone scan index can predict survival rather good. You see, if you have a high value, the survival curve is going down, whereas if you have, not only if you don't have any metastasis, but also if you have a low value, there is quite good prognosis. And we also compare that to what the oncologists often use for these type of patients, the prostate cancer patients, namely the PSA blood test, the prostate-specific antigen, which is used quite a lot to see how the patients are doing. We have compared that in different statistical analysis and also in these type of Kaplan-Meier tests, and show that bone scan index better separate sort of the groups with good and bad prognosis than the PSA value. And that is also doing cost regression, where we can compare the importance of the information content regarding survival between these 2 parameters, and that showed that bone scan index is by far the most important variable of these 2 regarding survival. So this is something we are looking into in different cases now, both in New York in collaboration with the Hospital Memorial Sloan Kettering in New York that are very interested in this, and also in Denmark, looking into survival, but also things which is important for these type of patients, the risk of having a skeletal event, for instance a fracture or compression of the spinal cord. So can these things also be sort of predicted by quantitative measurements? That is something we are looking into right now. So I think it's a very interesting field with quantification also in oncology, not only cardiology. And finally, some words about reporting as structured reporting. I'm taking two citations from American Society of Nuclear Cardiology and their report or guidelines about standardized reporting of radionuclide perfusion and function, where they propose how to report these type of scans. And their view on this, and they are similar in other societies where they propose how we should report, is that when we move away from open reporting, just dictating, and implement structured reporting, this is expected to improve quality, outcomes, and to reduce costs. So they think this is a way forward. But they also mentioned that the appearance of the standardized report can and should vary from user to user. So standardized report does not mean that the report will be exactly the same all over the world. We don't need to sort of agree on one way to do this. But this is sort of to inspire people to think over what is a good standard at my hospital. How can we sort of standardize the sentences, the expression we use in the reports, how we with headings and images and so forth. So most of the reports are sort of very similar and easy to read for the cardiologist, oncologist in my hospital. And that is why we have found that in the software we developed in ESNMS, which we use in the hospitals where I work, we have sort of implemented in this work for cardiac scans the guidelines of the American Society of Nuclear Cardiology. But we also have discussion among the doctors at the nuclear medicine department. What type of sentences do we want to use? And we have also had a discussion with the cardiologist. How do you want to have the reports? So we serve them as best as we can. And then, so that these changes can be easily be implemented in the software for integrated diagnosis. In the beginning, of course, as always, when you implement new technique, this is sort of takes some time, especially for the discussions and implementation of that. But when we have done that, we can see that reducing the reporting time. Not only for complicated cases, but also for perfectly normal cases where sort of the proposed reports by software can be accepted in most cases. So, as if I get the question now, do I need software for quantification and configurated diagnosis? My answer today is yes, we want to use it in the hospitals where I work we do this now for the four different types of examinations: cardiac scans, bone scans, which I've talked most about, but we also do this for brain scans, where we have a quantitative toolbox, which I think makes it easier for us to interpret these scans, and also the latest one, that scans that's for Parkinson's disease, which is specifically used for the quantification for these borderline cases where you don't really know if the patient has Parkinson's disease or if this is a sort of essential tremor where the patient doesn't benefit from having a treatment over a long time. So this is also an interesting examination in nuclear medicine. So we do this to have sort of a good quality of the reports. That's the reason we do it, that we know that we have sort of some control over the quality of all our reports we send out from the department. That was my last slide. Thank you for your attention.